to absorb that shock. Basically, it's just fibrocartilage rings. They help cushion the joint, stabilize it, and they also balance our weight. And I'll show another picture of that. In this coronal view, not only do we have cartilage within around the knee, but we have this layer of meniscus that is like a spongy type of a fibrocartilage. And you have a lateral meniscus and a medial meniscus. And in the sagittal plane, we have an anterior horn of the lateral meniscus and a posterior horn of the lateral meniscus. And vice versa with the medial meniscus too. We see those best in the sagittal plane. And this is a sagittal image of the knee. Anytime we're looking at or you see these bow tie appearance, it looks like a bow tie, doesn't it? They are little triangles here. This is your meniscus, okay? And you have an anterior meniscus and a posterior meniscus, okay? And you have either then a lateral anterior horn of the lateral meniscus and an anterior horn of the medial meniscus. Well, ligaments, tendons, menisci should always be dark on MRI images, on all pulse sequences. What radiologists then look for is, you can't necessarily maybe see it on this slide, but you can see it better in or on your laptops. Do you notice that there is a white line? That's kind of in the middle of that. That's considered a tear of the meniscus. And radiologists will grade that tear. If it goes all the way through the meniscus, they might call it a grade 4 meniscal tear. If it only extends like part way, then they might say it's a grade 1. They look at how far, how much is it cutting through the articular surface of the meniscus here. And the radiologist will grade that then. Okay? If you have a complete tear, then maybe you'll need to have a scope done on your knee, a meniscal repair. If you just have a slight tear, those generally will heal on its own. Okay? As you get older, sometimes we don't even see the meniscus at all because it's degenerated. Okay, so they have degenerative changes in the knee. But for MRI, this is one of the major reasons we do MRIs of the knee, is to look for these tears because you can't see them on any other imaging modality. We don't see them on CAT scans. We don't see them on X-ray. The only other way to see if you have a tear is to actually have a scope done, but that's an invasive procedure, okay? So MRI plays a huge role in orthopedics because we can look at tendons, menisci, ligaments so clearly. This is a nice, I think, representation of what our menisci should be doing to distributing our weight, okay? You know, we don't want most of our weight to be on that back of the tibial bone or even on the front of that tibial bone. We want it to be dispersed evenly on our tibial bone, okay? And again, this is a nice picture of, we can see a complete tear going all the way through this particular meniscus.
When we're just looking at these, how are we supposed to know like what's medial and lateral?
Yeah. And I'm going to give you a hint to that as we, towards the end here. Okay, yeah, a good question. Because it is hard.
Yeah.
This is just an animated cutaway of what your menisci looks like on top of that tibial bone. And they look like just C structures here. Okay? So then picture your femur coming going on top of this. Kind of already talked about anterior horn, posterior horn. We have lateral and medial here. Generally, the lateral is going to be more when you see the patella in your image. Now, I can also see probably part back here is part of that fibular head. I know the fibula is lateral, right? So if I can see the fibular head, then I know this has got to be my lateral meniscus. Also, if you set up your slices the way you're supposed to set them up, with this angle we're going to talk about, if you see your patella, that's generally going to be on the lateral aspect. And I say generally because, well, if your patellar is dislocated, and if it's slid to the medial aspect, well, you can't really go by that then, right? But in a normal setting, once you see that fibular head, once you see the patella, you can assume I'm looking at the lateral meniscus. But now notice radiologist has, and this is only looking at one image, so sometimes that's what it's hard to really know. But radiologist has the whole series, right? So by paging through them back and forth, you know for sure which is lateral and which is medial, okay? Just by knowing your anatomy. Here I can see part of the patellar bone, but I can't see any of the fibular head. Then I'm going to assume this is going to be the medial meniscus, okay? Okay, well, let's go to the circulation of the knee, the innervation of nerves in the knee. We know from studying the back and studying the hip and the femur now that you have a sciatic nerve that runs down the back of your leg. Well, that sciatic nerve then branches into a peroneal nerve and a tibial nerve. So this is your sciatic nerve coming down. And at this knee area, it branches into a peroneal nerve and a tibial nerve. And it goes in the back of the knee, which is really why that sciatic pain goes all the way down the back of the leg, right? So if something's pinched in the back, in your lower back, you might have pain that goes to the back of the knee. Well, is it a knee problem or is it really a back problem? Well, that actually has to be then clinically assessed by the doctor to know what do we need to do an MRI of. You also have your femoral nerve that branches into the saphenous nerve, and that comes more to this side of the knee, okay? So again, everything in our body stems from our spinal cord and our brain that sends nerves to the other parts of our body that has to carry information back to our brain, right? Pain, numbness, tingling, all of those types of issues, burning, okay? The circulation, well, we know that there is a femoral artery that comes down, then it branches into a popliteal artery. That also goes to the back of the knee. And the popliteal artery can cause us some flow issues in the back of the knee. So when we're scanning the knee, it's important then to understand, well, what is my direction of phase then? Because I want my popliteal flow to go in either this direction or another direction, okay? So it's important to understand where this popliteal artery is at, and it's in the back of the knee. When we are scanning a sagittal image, well, think about a sagittal. Try to picture it in your brain. And the popliteal artery is in the back of the knee. And if I'm doing a sagittal, what two planes or what two directions of phase can I have in a sagittal?
Anterior, posterior,
right, so what do you think you would want your phase direction? Correct, right, so for your sagittals, you want your phase direction to be S to I or head to foot, because you don't want that flow motion coming into anterior posterior of your knee joint, okay? Because we're looking at menisci. So if there's going to be a line going through your menisci, you don't want that to be an artifactual line. You want it to be real, right? So that is, why it is important to understand phase direction. And I think we've talked a little bit about flow comp or gradient moment nulling, because for your T2 weighted scans, you can turn on flow comp, which will help compensate flow in that direction, okay? Okay, so that's basically the bulk of our knee anatomy. We know the bones in the knee, really only what? 4 bones. The femur bone, tibia, fibula, and you got your patella, right? And then we talked about the ligaments, talked about the tendons, talked about the menisci, talked about the nerves, and we talked about circulation. So pretty much we've covered now all the anatomy in the knee joint itself. Let's go